Mr. Anthony, a 67-year-old male who is a fisherman by occupation, residing at Kanyakumari, outside 7th standard, and belonging to lower socio-economic status, came with chief complaints of difficulty in walking for 4 days, hoarseness of voice for 3 days, difficulty in swallowing for 3 days. History of presenting illness. Patient was apparently normal 4 days back. Then on 4/2/2025, morning at around 2:30 am, he woke up to use the restroom. He got up from the bed without any difficulty, and he found that he had difficulty in walking due to unsteadiness. He was swaying to his left side when he tried to walk. He managed to walk with the support of the wall, and then he slept again. He woke up by 6 am and realized that he continued to have swaying with the same intensity. In the same day, he had food without any difficulty and slept. Next day morning, when he woke up around 6 am, he asked his wife for some water. His wife noticed that he had hoarseness of voice, he had difficulty in swallowing and nasal regurgitation while drinking water. He had decreased sensations over the left side of the face. He was then brought to our hospital around 8 am. After reaching EMT, he developed hiccups. Rice tube was inserted and he was admitted in IMCU for 1 day and later transferred to ward. No history of difficulty in raising upper limb above the head, mixing the food using fingers, holding the slippers, raising head from the bed, turning the head from side to side, rolling over the bed, consciousness or orientation. No history of memory, speech, behavioral or emotional disturbances. No history of disturbance in appreciating smell, blurring of vision, disturbance in appreciating color, drooping of eyelids, double vision, difficulty in moving eye in all directions. No history of deviation of the angle of mouth, stasis of food, drooling of saliva, hard of hearing, tinnitus or vertigo. No history of nasal regurgitation of food and nasal twang of voice. No history of difficulty in turning the head from side to side, appreciating sensation of the cloths, appreciating hot and cold. No history of difficulty in appreciating pain, tingling or numbness. No history of involuntary movements, difficulty in reaching the objects, difficulty in bringing the food to the mouth. No history of difficulty in initiating micturition, frequency, urgency or incomplete evacuation of the bladder. No history of bowel disturbances. No history of fever, vomiting, headache, injury to the head, neck stiffness, chest pain, palpitation, diarrhea or ear discharge. Patient is a known case of type 2 diabetes mellitus and hypertension for 5 years and on regular medication. Past history.
The previous slide, small correction, your dosage of the uploaded peanut. Even this very minor one. Dosage available is not 4 mg, not 40 mg. It's 5 mg and 50 mg. It's only minor correction, but you should know the individual strengths available in your authority. Might be having a different strength when you go abroad. But here available is 5 mg and 50 mg. And the first point in your presentation, already the presentation on the previous case also highlighted about that reliability of the informant, which is not mentioned by you. Even the patient is going to tell you the history. You are not relying on the others. Sometimes you can get a blabbering of the patient, which may not be having meaning, which you cannot rely on. It's very important for you to make a comment on any neurological system examination case. Exam is concerned. You always mention about informant, patient or self or the wife or relatives, third degree relatives or second degree relatives. Reliability has to be mentioned. It's very important. Okay, yes.
Past history. Patient is an old cerebrovascular accident patient, left-sided hemiparesis in 2019 and recovered fully. No history of rheumatic heart disease, ischemic heart disease, tuberculosis, bronchial asthma, seizure, sexually transmitted disease. No history of prior surgeries. Family history. No family history of stroke, migraine. No family history of cardiovascular events. Personal history. Patient follows non-vegetarian diet. Sleep is normal. Bowel and bladder habits are normal. No history of smoking and alcoholism. No history of any drug abuse. Summary.
Before moving to the summary, sorry. The past history you mentioned about stroke. So what was,
treatment history.
I was waiting for that you are going to present the treatment history that is missing
I
here.
was also same thing.
I was waiting, but you didn't
Most of the
mention.
examiners are like-minded.
But you didn't mention about. At least if you have mentioned this treatment history here, so why is going to second time of problem with the neurologic?
When you get a first stroke means doctors will ask you to take some medicines lifelong. So even otherwise in the history, the headings include present, past, personal, families, treatment history, female and I would say menstrual history,
Allergy
then
history.
psychosocial history, children and nutritional history. So all these are
Additional history to
treatment
mention.
history is an important aspect of medical business.
Just trying to blame the what I call non-compliance of the patient to explain this correct event or the new event, even the patient was very compliant. Some sort of thinking will run into your mind regarding the etiology of the current disease. So it has to be thought about properly. So that's very important. If you're going to give a separate column of treatment history, well and good. You could elaborate.
Treatment history also separately.
It's applicable
Two
for
problems are there. One is drugs like the patient is on drugs like ecosprin or warfarin, that can cause bleed. Or inadequate treatment can lead to future stroke. Both can happen.
it's not only this system, even respiratory system, asthmatic patient, COPD patients, cardiovascular diseases.
Review of systems not mentioned. Other systems you have mentioned.
Not mentioned.
Not mentioned. You are supposed to mention during history. You are supposed to mention that treatment aspects, any surgeries done in the past, a review of other systems. Even if it is a neurology case, you have to mention about problems occurring in other systems. Does he have any cardiovascular chest pain, palpitation, and irrelevant negative parts, any chronic cough, any other systemic symptoms, SLE-like symptoms, joint pain that you can just mention and weight loss, fever.
A 67-year-old gentleman with type 2 diabetes mellitus and hypertension and on regular medication with past history of cerebrovascular accident, left hemiparesis, came with chief complaints of difficulty in walking because of swaying to left side for 4 days, hoarseness of voice, difficulty in swallowing, nasal regurgitation and hiccups for 3 days, with loss of sensation over the left side of the face without any weakness of the limbs. This is a case of acute stroke syndrome, probably thrombotic etiology.
So the understanding of the what Sir was mentioning about localization, now slightly more into the depth of the understanding your history of your patient, where you want to further refine your diagnosis part, last part. Slightly extra point I'm expecting you to tell. Even that was initial understanding of yours reflected here. After listening to Sir's presentation, where do you want slightly extra?
Maybe posterior circulation stroke.
What are the points? Or tell me the
Sir is
symptoms.
asking the anatomical structure. Name of the anatomical structure.
Brainstem.
Brainstem. Where in the brainstem?
Lower cranial ambassador, so medulla.
Medulla. Because 9 and 10 cranial nerves occur in medulla.
So what are the points? Tell me the symptom and cranial nerves. Swaying is there, what is the reason? Hoarseness of voice is there, what is the reason? Difficulty in swallowing, what is the reason? Nasal regurgitation due to what? And hiccup. Tell me the each point and cranial nerve or what are the structure you want to say.
Hoarseness of voice is because of the 10th cranial nerve involvement. Nasal regurgitation and difficulty in swallowing 9th and 10th cranial nerve involvement. Swaying may be a cerebellum involvement because of spinocerebellar tract in the medulla. Cerebellar peduncle.
Okay. Loss of sensation. Face.
Sensory trigeminal nerve involvement.
Fifth cranial nerve involvement. Which part?
Sensory parts.
Any weakness of the limbs. Okay. So you want to say that problem at the brainstem level, territory wise, arterial territory wise?
Vertebral artery, posterior cerebellar.
I can say that this posterior circulation is enough for the undergraduate level. Then thrombotic etiology. Why this is thrombotic etiology?
It is a wake-up stroke that patient develops at early morning and gradually progressive. It is ever.
Is it common to have a hemorrhagic stroke in the brainstem?
Posterior communicating.
Somebody said. Spontaneous region can have hemorrhagic stroke. Midbrain very less likely to have a hemorrhagic stroke or less likely to have isolated involvement.
Pons is actually a very small structure anatomically. If the hemorrhage occurs in pons means it is a very light trouble.
Full blown disease.
Full blow. ഇതുപോലെയല്ല patient അപ്പോൾ 3 piece എന്ന് പറയില്ലേ 3 piece in pons patient fully മാത്രമല്ല there will be bilateral involvement. Patient get a quadriplegia. When there is a hemorrhage in the pons, there is a both corticospinal tracts should be affected. And this because the hemorrhage is large and it will compress bilateral. So patient will get a full paraplegia, quadriplegia, and with pinpoint pupil, much more devastating nature. This typical lateral medullary syndrome is usually an infarct. I have not seen a bleed due to lateral medullary. Lateral medullary is majority case is infarct.
Yes. Next.
General examination. handedness, right-handed. Patient lying on the supine on the bed comfortably. He was conscious, cooperative, obeying commands, oriented to time, place, and person. He is moderately built and nourished with a BMI of 23.2. No pallor, ictus, clubbing, cyanosis, lymphadenopathy, period edema, no neurocutaneous markers and markers of tuberculosis, HIV and syphilis.
General question to you. What is the BMI of this 23? Or is it moderately built?
Have you taken the height? Nourishment is based on this food. Build is usually based on height only. Somebody with short stature is a poor build.
BMI is okay for Indian culture. Is it obese or poor? Normal BMI. As per WHO, it's a normal BMI for Indian origin, right?
Vitals. Pulse rate 72 beats per minute, regular rhythm, normal volume, no specific character, no radiofemoral or radio delay, artery wall not thickened, all peripheral pulses felt equally. Respiratory rate 18 breaths per minute, abdominal thoracic type. Blood pressure 130/80 measured in left upper limb. Temperature 37 degrees Celsius, JVP not elevated.
Any stroke patient and cardiovascular case, at least measure the blood pressure at least
2 limbs.
At least 2 limbs, upper and lower limb. If you have the time, can mention all the 4 limbs. Ideal to measure. Never miss that. Okay? Yes, already mentioned about the carotid is missing. But also can be mentioned. It's not part of your examination. Sometimes you will be seeing a patient with a paraplegia or monoplegia or systemic involvement of quadriplegia also. The reason could be metabolic reason, thyroid disorders. That also has to be kept in mind. Any cardiovascular neurological disease, you can also examine the thyroid gland as an important part of your examination, other than the carotid. Okay.
Nervous system examination, higher mental function, right-handed person, appearance, muscular clean, gait, ataxic gait, conscious, oriented to time, place and person, memory, immediate, recent, remote, intact, speech, spontaneous speech, comprehension, naming, fluency, repetition, reading, writing preserved, dysarthria present, calculation, normal, able to identify the left and right side of the body, education status is 7th standard, sleep pattern and emotional status is normal, no delusions and hallucinations. Cranial nerve examination. First cranial nerve and olfactory nerve and optic nerve, both right side and left side. No specific findings. Oculomotor nerve, trochlear nerve, abducent nerve. On left side, pupil is small, mild ptosis is present. Fifth cranial nerve.
Partial ptosis or complete ptosis?
Fast.
I mentioned it layers.
Mild
Instead of
ptosis.
using the term mild, we would say partial ptosis or complete. There's a better term. What is the difference between that partial ptosis and complete ptosis? Because in Horner syndrome, generally you get partial ptosis. As in Gardner palsy, you get complete ptosis. So what is the how you what is the criteria by saying it is partial or complete? I will see whether the pupil is fully covered or not. The pupil is fully covered and not visible, then it is complete ptosis. The other one is a just ptosis. And which condition was fatigable ptosis? Fatigable ptosis means normally there is no ptosis, but when person tries to read or something, Harrison again the 2-3 page is developing ptosis means the myasthenia.
What is pseudotosis? Dorsal involvement or lid involvement producing, or edema also can produce partial ptosis like picture. It's not true ptosis. What is reversible ptosis? How to demonstrate that? Uppercut waves, uppercut waves.
Ice packs.
Cold application. Cold application. Cold application will reverse the ptosis part. So this myasthenia pointer. Go and read why it's reversed. So something to do with acetylcholine part. Right? Go and read about that. Yes, go ahead.
Fifth cranial nerve, trigeminal nerve, right side sensory
Eye
motor.
movements are normal. Because in third nerve palsy along with the ptosis, because third nerve supplies not only levator pulmonary supply, it's also supplying the extraocular muscle. So if it is a ptosis to the third nerve, invariably the eye movements are affected and patient will get double vision. And whereas in Monar syndrome, eye movements are normal.
Fifth nerve, trigeminal nerve on left side, sensation over face is lost, motor clenching of teeth is normal, reflex, corneal conjunctival present, jaw jerk is absent. All sensations. Seventh nerve, facial nerve, both motor sensory reflex, right side and left side are normal. Vestibular cochlear nerve, Rennie's test, Weber's test, right side and left side are normal. Glossopharyngeal nerve and vagus nerve, uvula, deviated to right side, gag reflex and palatal reflex. Left side it is absent. Spinal accessory nerve and hypoglossal nerve, both right side and spinal accessory nerve, right side and left side normal. Hypotension, no atrophy. Palpation on right side, mid upper circumference 29, mid forearm 27, mid thigh 43, cough 37. On left side, mid upper arm is 29, mid forearm 26, mid thigh 43, cough is 37 centimeters.
In presenting this, especially the measurement, in the previous presentations we noticed, instead of mentioning about the numbers, you try to interpret and tell the finding. Like 2 centimeter difference, 5 centimeter difference. It's like a measurement made by a tailor, and making the examiner to interpret it doesn't look nice. Try to tell what is interpretation. Okay.
Don't in upper limb and lower limb flexor extensor on both sides are normal. Power, movement of the shoulder joint, elbow, wrist joint, hip joint, knee joint and ankle joint. On right side it is 5/5, on left side it is 4/5. Reflexes, so superficial reflexes on right side and left side, corneal, conjunctival, abdominal present, plantaris flexor, deep tendon reflexes, biceps, triceps, opinator, knee and ankle are present on both right side and left side. Coming to sensory system examination, spinothalamic sensation on right side, pain, temperature, pressure is lost, left side it is intact, posterior column sensation, both right side and left side are intact. Cortical sensation, both right and left side are intact. Coordination system, in upper limb, finger nose test, finger test, draw a circle in air, distal kinesia, left side not able to perform, right side able to perform. Lower limb, heel knee test, draw a circle.
Not able to perform, or you can say not able means somebody has grade 0 power means he cannot perform. He has already 4/5, so he can perform. So you tell what is abnormality when you try to perform. You can say there is incoordination, or there is what are the expected findings when you do a finger nose test. What do you expect? If I will do some things, you can tell what I will do. So suppose person is doing this, what doing like this. What is this? Dysmetria, hypometria. Suppose this one is hypometria. And what is this one? These are the things you have described. You have tell whether it is a dysmetria, hypometria, or intention tremor. Not able to perform means you failed in that test and you are not getting an interpretation. So you have to specifically tell, is it a dysmetria, hypermetropia, or it is a, what is the, how will you identify the cerebellar tremor? Tremor can happen in Parkinson's also. How will you know it is cerebellar tremor? It aggravates towards the target. When a person comes like this towards the target, it is increased. And there is a overshoot. And what is the direction of movement I am showing? Is it like this or like this? Direction of movement is perpendicular to the axis of movement. And is it a fine or coarse tremor? What is the difference between fine tremor and coarse tremor? This one is fine or coarse, like this. Here the amplitude is less, but frequency is high. This one means the amplitude is higher, but frequency is less. That is coarse tremor. So things you can describe are whether we have a coarse tremor, intention tremor, whether there is pass pointing, dysmetria, like that you have. It's not able to perform, it's not a suitable term there.
The previous slide, the sensation of the face, you mentioned about pressure. What does it mean by pressure? Yeah, pain, temperature, and pressure. I asked you about is it the spinothalamic and posterior column? You said yes. No, you mentioned intact both sides. You mentioned right. Because the sleep column only involved, you have to mention about pain and temperature, the main sensations getting lost. What is the pressure here? Crude touch. Right, it is crude touch.
No extrapyramidal signs, no involuntary movements, no signs of meningeal
There is
irritation.
tremor that is considered as a involuntary. Suppose there is a coarse tremor or intention tremor, you have to describe that there is a coarse tremor with high amplitude and there is a intention tremor that is considered as a involuntary. That is the expected finding. All findings is not there in all patients. You can tell only findings which are there.
8. Ataxic gait, no carotid or bruit. Other system examination, cardiovascular
You
system.
can carotid bruit or some other bruit, posterior sublateral stroke, which vessel is suspected. Vertebral artery bruit. So you can sometimes see suboccipital region also.
Which carotid you are looking for? Basic question. Which carotid you are looking for?
Internal carotid.
We have only three, right? As a main gas carotid, you have a common carotid, internal carotid, external carotid. Which carotid you are looking for? Not it. Somebody said internal carotid, you also said internal carotid. Will you able to palpate external carotid externally? Will you able to palpate internal carotid externally? The artery which you are trying to look for as a carotid pulsation is a common carotid. You can palpate very well external carotid because the bifurcation is happening at the level of the 6 upper part. That is your the thyroid cartilage upper part, you are able to get the bifurcation. But the internal carotid goes beneath your the sheath and making the prominence of your external carotid alone. The artery pulsation which you are palpating at the angle of the mandible is your external carotid pulsation. Below which is common carotid, that's a common area where we palpate. Looking for carotid pulsation. The examiner asks you to palpate, you have to palpate only this part. Whereas this part you are going to palpate is going to be external carotid. Very important applied anatomy point of your internal carotid artery is not palpable. Other important applied anatomy part is for internal carotid is only arterial pulse which can visualize is internal carotid artery. Which artery? The only artery of your human being can be visualized, the pulsations can be visualized. A branch of internal carotid artery. So the only artery which can visualize is ophthalmic artery. So two important applied anatomy. Third important applied anatomy is where you want to palpate the internal carotid artery, which you will learn during your ENT subject. Pardon? A patient is undergoing, for example, giving a clinical scenario where patient is undergoing tonsillectomy. Okay, there are multiple reasons for post-tonsillectomy hypotension or bleeding. One is 24 hours later, one is going to be before that. Before shifting the patient from the OT to the recovery room, the patient is got certain hypotension. What are the common causes for post-tonsillectomy? Sudden torrential bleeding post-operatively immediately before shifting to recovery room. Okay. Hypotensive shock. Hypotensive shock. Because of the injury to the tonsillar bed structure. The tonsillar bed structure is going to, major artery is going to internal carotid. That's where it comes into. So the artery, internal artery is palpable only internally. That is the tonsillar fossa. That's where you can palpate the internal carotid artery. External carotid artery, common carotid, internal carotid artery go inside. It's the commonest reason for sudden hypotensive shock, immediate post-operative. Not the suture ligation removal alone, it is the damage to the internal carotid artery. Okay, yes.
Other system examination, cardiovascular system examination, S1, S2 here, normally in all areas, no added sounds or madness. Respiratory system examination, chest movements equally bilaterally equal, normal vesicular breath sounds, no added sounds. Periabdominal examination, soft, non-tender abdomen, no abdominal. Summary, yes, 67 years old male, came with 4 days history of dysarthria and ataxic gait, with diabetes mellitus and hypertension for past 5 years under regular medications. On examination, there is sensory loss over the left side of the face and the right side of the body, mainly involving the pain and temperature, with features of Horner syndrome on left side and left-sided 9th and 10th cranial involvement. Diagnosis: this is a case of acute stroke syndrome involving the posterior circulation, probably a vertebral artery due to thrombotic etiology affecting the left lateral part of the medulla without any complications.
Diagnosis, you can enumerate the neurological deficits also in there. So you can say cerebrovascular accident. So site to offset medulla, artery offset vertebral artery or pike. Neurological deficits you can enumerate in there. Artery offset in some of the well, neurological deficits. Semi-cerebral loss, Horner syndrome, cerebellar ataxia, all these are neurological deficits. Risk factors. That also you can mention. Risk factors. Age, diabetes and alcohol.
I think all of you are able to arrive at this clinical conclusion. Why they arrive at this localization of the lesion? Probably the class previously would have made you to understand the current the patient, what they are trying to reach at is easy for you to understand, right? Yes. You will not dwell into much of this part. How are you going to proceed further? Because we not spent much on the investigation part last case. How are you going to proceed further now? How much time it took for the patient to reach to your site? Emergency department? How much time it took for the patient to reach emergency? 1 day after 24 hours later the patient reached. Okay, what is the plan of management? Starting from investigations and medications.
Investigations to decide whether it is thrombotic or hemorrhagic etiology. We want to take non-contrast CT scan of brain. In case of hemorrhagic stroke, there may be a hypertense lesions may be present, or in ischemic stroke there may be hypotense, and other investigations include ECG for looking any latest fibrillations, or echocardiography for any mitral thrombus, or bilateral carotid artery Doppler, and other to rule out metabolic conditions.
If you want to do a Doppler, better do carotid vertebral Doppler, because we are dealing with the posterior circulation. Want to only carotid. So better to remember that CV Doppler. If you're very specific vertical artery, but you're always justifiable to go for carotid vertical artery. There is a neck vessels is always applicable. Okay, so don't say only carotid. It has to be both sides. Okay, and always when you're asked investigations, always try to tell the question is open question. Better to answer non-invasive followed by invasive investigations. Don't start with invasive. If you're asked a specific question, what is the diagnostic? Whether invasive or non-invasive doesn't matter. You have to tell the single investigation. Understand? So try to listen to the examiner's question. Is he asking for open question or closed question? Be more specific on that. Okay. So what is the role of hemoglobin in this patient? Suppose smoker, what is the role of hemoglobin? It's better to say erythrocytosis. Okay, erythrocytosis can be there. That can be one of the reasons for the current episodes. Suppose found to have a very, very low hemoglobin. What are the additional possibilities you can think about? Stroke patient admitted, low hemoglobin, microcytic hypochromic anemia, having macrocytic anemia. What are the possibilities you can think about at your level of learning? For macro or micro? Macrocytic. I am talking about deficit and hemoglobin. I am not talking about this patient alone. Suppose microcytic. 67-year-old, I was asking about smoking history and other system-related queries. So keeping in that mind, if person is having low hemoglobin, microcytic anemia, anything else can think about.
Maybe any chronic disease or any
Like?
chronic disease like tuberculosis, yes, tuberculosis.
No itching. Examination or body language is very important. Trying to tell you about, because this is a area you can make mistake. I'm not criticizing you, just telling you how to behave in the examinations. Because making these exercises are preparation for your examination, right? Yes.
Chronic conditions like tuberculosis, voltage, maybe rheumatoid arthritis.
Related to neurological system, whatever the symptom what you are dealing with. Then we can think about malignancy, very important malignancy, infections like tuberculosis. If you are remembering one or two conditions, you'll be able to answer spontaneously. Then you have some breathing time for think about. I'm talking about just small, important, anticipated questions. Prepare yourself for the one or two answers, followed by take a breathing time, then go for the answer. That will be okay. Okay? Yes.
In this case, CT or MRI will be better.
24 hours later.
Because medulla is better seen in CT, lateral medulla may not be seen in CT. MRI is the investigation of choice. In this case, MRI may show multiple infarcts because previously also you had a stroke. So what do you know about multi-infarct? What are the possible outcomes in a multi-infarct situation? Because patient can come in first time infarct, previous infarct may be also there. Suppose you had infarct in right side of the brain and left side of the brain. Sometimes you may get right internal capsule infarct, left internal capsule infarct. Eventually, what are the outcomes it can happen? Like, what are complications of multi-infarct? One is dementia. That's called vascular dementia. Persons with recurrent infarcts will develop dementia. Have you heard of pseudovalvar palsy? Now, what I tell something about pseudovalvar palsy and how is it related to multi-infarct?
What is the meaning of pseudo-bulbar palsy?
What is the how person gets pseudovalvar? What do you mean by pseudovalvar? Tell something I don't know. You tell then that is what. You teach me what is pseudovalvar, how it happens, why it happens, what are the manifestations. Open question means it is you can start from.
Yes.
Your case is bulbar palsy or pseudovalvar. This particular case is bulbar palsy or pseudovalvar palsy. This is a case of bulbar palsy. Because bulb means it is medulla. What do you mean by bulb? Tubulate. It is the ninth and part of the medulla carrying ninth and that portion is called medulla. So when something happens to the medulla, it is called bulbar palsy. So what is pseudovalvar palsy? Pseudovalvar palsy means medulla is normal, but the connections to the medulla is lost. So what is the peculiarity of these connections? Connections are always bilateral. 9th and 10th nuclei have bilateral connections. So what should happen to if there is a In order to get a UMN lesion to cause pseudobulbar, what should the peculiarity of the lesion? Lesion should be bilateral. But unilateral lesions never cause bulbar palsy. But in this case, bilateral lesion is possible. Why? Because previously a hemiplegia, now also is the, but he has got bilateral. So whenever the persons get bilateral multi-infested, and when both corticospinal tracts are affected, eventually it will end up in pseudobulbar palsy. But in this case, it is medulla causing bulbar palsy. Suppose person got a right hemiplegia one time and after 3 months is getting left hemiplegia, medulla is not involved. A structure effect is interrogation. But that person can also end up in bulbar palsy. That is not real bulbar palsy. It is pseudobulbar palsy due to bilateral. So what's the prerequisite for pseudobulbar palsy means? The lesion should be bilateral. And there should be bilateral corticospinal tract lesion and it is above the level of medulla. So what are the points by which you say it's bulbar or pseudobulbar? Both will get 9, 10 more. We got gag reflex I mentioned. If it was pseudobulbar, what will happen to gag? Neutral, they are the presenters. So let them, if they don't tell, we will pass. You said gag reflexes. What is the finding in gag reflex in your case? Absence. Suppose it was pseudobulbar, what would have happened? I am saying this pseudobulbar. Gag reflex and jaw jerk will be brisk and patient will have emotional incontinence.